Anyway, the official topic that I was given, this is exactly as it was presented, is prescription drug detoxification concepts, which was a somewhat confusing topic to me. I wasn't quite sure exactly what they wanted. So I've got some stuff. In fact, I can hand out some just presentation of the slide and a few other things I've included. And maybe you can also direct me as to the kind of stuff that, here we go, the kind of stuff that might be relevant to you with regard to this overlap between pain and addiction. To what degree are you seeing it? To what degree is it an issue?
It's always an issue.
Yeah.
We do the patient agreement, and then you always worry what's next. If they're just addicted or just at what point you have to change medication, at what point you have to start talking to them about something else.
It's a tricky problem.
How much to give them medication versus procedures.
Yeah.
What age they are.
It's a tricky problem, and it's tricky because the overlap between addiction and pain is such a difficult overlap to, there's such a grey area. And I must say, my background, I'm a psychiatrist who's subspecialized in addiction and understanding addictive disorders. And I think that some of the more difficult patients that I have to treat are patients with chronic pain issues and addiction issues. Very confusing, very difficult to draw the boundary. Also very difficult because of the subjective nature of pain and the subjective experience of pain. Now, I think one of the important things in looking at this area is having some sense of what we mean when we talk about addiction. Because I think it becomes very, very confusing for a lot of people, defining addiction. And I'm using a behavioral definition. You could say a behavioral manifestation of a medical problem, of a medical disorder. And this is a conflation of a few different ways of looking at work. I don't know if you know George Koob, his work. He's done a lot of animal rat modeling on addiction. But I think that to understand it, one can look at these criteria and I think understand it from a behavioral point of view. If you think about what leads someone into addiction, you're exposed to an experience, whether it's the feeling you get from drinking alcohol or taking some oxycodone, or pulling a slot machine in Las Vegas. And the feeling is a very good feeling for some people, a very, very good feeling. And obviously, if you experience something that you really like, it leads you to come back again. And again and again, you want to replicate that feeling, and you start thinking more about it. And so you start developing a wanting, which is termed craving, a conscious desire for more of it. I really like Lindt chocolate. I really want more Lindt chocolate. As that begins to progress and develop, that wanting starts to take on a more powerful impulse to use and starts developing a compulsive quality, what George Koob has called a preoccupation anticipation. You are now finding yourself being drawn very powerfully to that behavior, that activity, to that substance. As that progresses, so a third element starts to climb into the equation, and that's this element of what I've called the crash, that there's a negative experience that starts to occur when you're coming down from that high or euphoria, or when you are blocked from getting it, what George Koob's called withdrawal or negative affect. So we see a progression. Addiction is not a single entity. We see a progression from a positive reinforcing effect, and I would argue that all addictions start with a positive reinforcement. There's no other way that it can start. You have an experience that you really, really like. You like it so much that you want it again and again and again. But that slowly there's a progression to a negative reinforcement, that you start being drawn to doing it to prevent the unpleasant feelings of not doing it. You may not consciously identify that. If we think of cigarette smoking, you want your next cigarette. Is it because you want your next cigarette, or is it because your nicotine levels are falling? And that becomes also and you have your next cigarette, it feels good. It becomes powerfully associated with other rewarding things, like walking outside for a break, after dinner, etc. As the cycle progresses, so we start seeing control loss, what George Koop's called binge intoxication, which is an escalation to a point where, for example, okay, I'm going out to the bar tonight, and I'm just going to have 3 drinks and be back by 10 o'clock. And, once again, you have 20 drinks and you're back at 4 o'clock. So I'm going to have a week where I'm not going to have any alcohol or whatever it is. And, a day and a half later, maybe I'll have some. And that's George Koop is called binge intoxication. And finally, the fifth element is continued use despite consequences. What others have termed, for example, Nora Volkow, who heads NIDA, has termed aberrant decision making. That despite the fact that you're starting to realize that, I missed my pain didactic on Wednesday morning because I was too hungover, I'm definitely not going to drink tonight. Somehow tonight you end up back in the bar, or, I'm taking my pain medication in ways that I should. I really need to stop, but somehow you end up doing it again. And so you start seeing a vicious cycle, and there's all kinds of research looking at the neurobiology of this. Now, notice that these are not DSM-4 criteria. And as a psychiatrist, obviously, I ascribe to DSM-4. Substance abuse, substance dependence, they're useful criteria, but I think they're confusing criteria. And I think when the next DSM comes out in the next few years, I presume you're familiar with DSM, you know what that is. It's probably going to look a little bit more like this. In part because, the big confusion comes, you're treating someone with chronic pain. You've got the patient on a stable dose of whatever you use, or Pana or OxyContin, whatever it is. Now, this patient takes that medication every day. If he or she stops the medication, he or she experiences opioid withdrawal. Does that person fulfill these criteria? Clearly not. But people get confused. So physiologic addiction, and that's where DSM's definition, say, of opioid dependence confuses people, because this is a person who's physiologically dependent to opioids, but yet doesn't fulfill criteria of an addiction. And I think you can apply these criteria clinically. I will sit sometimes with a patient and I will, say, do you think a lot about using the substance? What happens when you don't? Are you out of control in the way you use it? Do you continue to use it despite the fact that it's causing consequences? Usually, if you're having that kind of discussion, they've moved into this arena. Another concept which I think is really important in understanding addiction is the concept of the rush, the euphoric experience. So this is very important, and this comes from work by Nora Volkow's group, Stony Brook, and they were using methylphenidate here. On the left, the left square is from primate research, and what they were looking at is oral versus intravenous methylphenidate, and they were looking at peak concentrations in the striatum, they were using, I think, PET scanning techniques on these monkeys to see. And what we see is that whether you took it orally or intravenously, the peak concentrations were the same. The difference was that the time to reach those peak concentrations was very different. So intravenously, obviously, within a few short minutes, orally, an hour to an hour and a half. Now on the right, they took, I think they took cocaine, people who were cocaine addicts, and they gave them oral and intravenous methylphenidate, and they asked them to self-report the level of high that they experienced, how nice this experience was. And they did PET scanning using radio-labeled C-reaclopride to look at dopamine receptor occupancy, and they came up with some graph showing that the more rapid the rate of change of dopamine in the brain reward system, in the striatum, the more reinforcing or the more euphorogenic was this experience. So the slow increase in dopamine when you took it orally was reported, almost no high was reported, whereas giving it intravenously there was a very rapid report of this high. And I think that this is an evidence-based way of showing what we know, which is that the more quickly you can deliver a chemical to the brain reward system in the brain, and the more quickly that chemical can kick out dopamine, the more reinforcing it is. And it explains both ways, why certain ways of using substances are preferred and why certain formulations are preferred. For example, why heroin is preferred over morphine. Why is it preferred? Any ideas?
Faster rush.
Yeah, well, it's why does it have a faster rush? Why does diacetyl morphine have a faster rush than pure morphine? Well, it's a little more concentrated, but that's not really. It's more lipid soluble. It crosses the blood-brain barrier, and so is a more effective way of delivering chemical into your brain. Why crack cocaine is preferred to powder cocaine? Why patients will take your OxyContin and chew it to try and extract. I mean, why not just swallow it? They're getting the same dose ultimately, of the oxycodone. Why do they chew it? To try and get that rush, to try and get a much more rapid experience. Well, that's right, and why there's all this research now going into making formulations that can't be tampered or much harder to tamper, slow release formulations. So, one of the questions, is there more substance abuse in pain treatment settings? Yes or no? Yes or no? And just some of the studies that have looked at that. I mean, there's many have looked at it. For example, the pooled odds ratios of 1.6 for alcohol abuse dependence. So they weren't looking for opioid; they were looking for alcohol in people with versus without chronic back and neck pain. Chronic disabling spinal disorder is associated with 2.2 times high rates of any substance use disorder and almost 5 times high rates of drug abuse dependence than the general population.
So sorry to interrupt.
Sure.
My question
please feel free, by the way. Yeah.
When I see these studies, the real question I have in my mind is which one was first, the egg or the chicken?
Well, let me show you.
First the pain and then
let me point to the bottom study, which is a fairly recent study from the Journal of Addiction. Self-report comorbid chronic non-arthritic pain and substance use disorders. They looked at, well, it's self-reported, but they looked at what the temporal sequence. 58% reported their substance abuse preceded pain onset.
That's my only
35% said pain preceded substance abuse onset, and 6.5% said they came on at the same time. So surprisingly, this has not really been researched much. In fact, this is one of the few studies that's really looked at trying to understand the sequence of it. And here we see that almost 2/3 of people with substance use disorders in pain clinics were reporting that their substance abuse came first. So if you look back at some of the statistics, you'll see that the rates are elevated in pain clinics of substance abuse, but they're not massively elevated. But when you look at the third and fourth statistic, when you take substance abuse facilities and patients with addictive disorders, you see a lot of pain. Look at that. Chronic severe pain was experienced by 29% of patients attending an outpatient drug and alcohol treatment facility. In a methadone maintenance treatment program, 37% chronic severe pain, and a quarter in short-term residential substance abuse treatment program inpatients. So what's going on? That if you go to methadone programs, you go to Stuyvesant Square to the rehab program, you find so much pain, chronic pain. What's your theory?
My theory is not theory. I actually treat few patients in this. But here, these patients don't get any treatment for the pain. They just give them the methadone, nothing else. Instead of breaking down the methadone, for example, for 4 times a day. That might
Okay, so it's undertreated pain, but why do quarter of these patients at least have pain, chronic pain? Quarter. Now we're talking about a spectrum of substance abusers. I mean, we're talking about alcohol, cocaine, opioids.
For the lower research, and these people somehow started with the addiction, but they have also pain.
But why do they have more pain than the general population?
If I'm addicted and I am sort of driven by these episodes of euphoria, do I experience lack of euphoria as painful?
Well, that's one. I mean, it's probably beyond the scope of this talk today to understand what this interaction is. There's some theoretical stuff. There's a whole lot of modeling that's going on to understand why there's so much pain-related disorders in patients with chronic addictive disorders.
Well, maybe they have opioids. Maybe they have opioids like hyperalgesia.
Well, that's one theory, but only a certain percentage of these patients are opioid abusers. We're talking about cocaine abusers. We're talking about alcohol abusers. We're talking about a whole gamut. We're talking about benzo abusers. We're talking about a whole gamut of substance abuse patients. I don't know if anyone's looked at individual substances and look to see more specifically, and it would be an interesting study to look at it. Yeah, whether there's more pain in opioid abusers than in cocaine abusers. But there's all kinds of things. One of the things you'll notice, when you treat more severe addicted patients, is the level of what I call decrepitude. You look at any methadone program, you see, these people who are in their 40s, who look like they're in their 60s, and they're all walking with canes, and they all have all kinds of disorders, accelerated disorders, and there may be, some interesting ideas as to why that is. One of those is that, chronic medical disabilities and chronic addictive disorders, as with other psychiatric disorders, may be rooted in other things like severe adverse childhood experiences, etc. So that may be one of the links. Chronic substance abuse also probably exposes to medical problems and to substance use problems. I mean, how many patients do you see with chronic hep C, for example? Yeah. Now, what's the link? Pain and hep C. Now, we know chronic hep C itself can lead to certain pain syndromes, neurological syndromes. And HIV. Yeah, so those things, but is it just the chronic HIV and hep C that's exposing to pain, or are there other factors too? So I think it's an interesting thing to think about. Now, looking at non-medical prescription use, and understand, and I think this term non-medical use is a good term, because when you talk about abuse of your benzos, your opioids, misuse, problem use, aberrant use. It has I think this is just a broader, less judgmental way of saying it. So someone who is taking their their analgesic at night to go to sleep on a Sunday afternoon because they're bored is non-medical use. Whether it's more severe abuse or dependence. And this is from National Survey on Drug Use and Health, and we know that 2.8% of the US population older than 12 reported non-medical prescription psychotherapeutic medication use in the month prior to being surveyed in 2007. Vast majority of people were using painkillers. About a quarter of them were using tranquilizers and sedatives, so I presume mostly benzos. And then a smaller percentage using stimulants, drugs like Adderall, Ritalin. If we look at non-medical increases, the prescription type the drugs, particularly analgesics, account for the biggest growth area in current addiction. And when we look at where people report they're getting it from, 56% in this survey reported they got it from someone who got it from a doctor. Only a small percentage are buying these things on the street. So a large percentage of these drugs are coming from my prescriptions, your prescriptions, our prescriptions. And it's interesting, being diverted in some way. Any thoughts about that?
Nothing you can do.
Well, it's an interesting thing to think about, and it'll also be interesting to see the impact of some of the new formulations on all of this. But I think this, certainly I see a subset of patients who are chronic pain clinic denizens, to get. This is from 12th graders, just to give some sense of what people are abusing, and the red bars are non-medical prescription drugs. We can see, high up there, Vicodin, then some of the other medications, down the line comes OxyContin. Somewhere in there are the tranquilizers and the amphetamines. Now, they wanted me to talk about detoxification, and I think the important thing, if we look back to the definition of addiction as a behavioral disorder, is understanding that detoxification, by detoxification, I'm talking about getting someone from a point where they are physiologically dependent to a substance to a point where they're no longer physiologically dependent on that substance. That's not treatment of an addictive disorder. Detoxification is the first step towards treatment of the disorder. It's like stopping the bleeding. You first stop the bleeding, then you start dealing with the underlying, wound and the cause of the bleeding, etc. And I think that's really important, because I think a lot of people think, okay, you've got a problem, you've got to go to detox. Detox is the first step. Now, you sitting in your office, you people are really busy, you've got short time, and suddenly you're sitting there, you happen to do an opioid screen on your patient that came up with opioids you're not prescribing, morphine when the patient's on synthetic opioids or whatever it is. Patient said, doc, I have to admit I'm injecting heroin or whatever it is. What do you do then? Looking at your watch, you've got like 3 patients waiting, What do you do? How do you deal with it? You think, oh my God, I don't have time. How do you proceed with this patient? I see you smiling. I'm sure a familiar scenario. You just want to give the person the medication, get them out of there. You might say, can you wait? Let's bring the social worker or the psychologist on. But how do you deal with this? And I don't think there's any easy cookbook recipe. But I think the first thing you have to think about is what is the most immediate problem right now? What's the biggest danger to this patient? What does this patient need? And I suppose in essence, if you're identifying an addictive problem, the question is, how do you assist this patient to break the addictive cycle? In other words, if this patient has become dependent on medications or has compulsively lost control of their use, how do you break that cycle? How do you help them to break that cycle? Do you say, well, I'm giving you a month, and if you come back and your urine's positive, then I'm kicking you out the clinic. You say, I'm not giving you any more medications now, don't come back. Is that good for your patient? Is that not good for your patient? And, I know that there are all kinds of scenarios. I have a fair amount of contact with the pain clinic. We have fellows that go there. So, I think different people have different approaches to dealing with these problems. And I think that, the first quick calculation you have to make in your head is, to what degree is this person acknowledging a problem, and to what degree are they asking for help? Now, that's the first question. If someone, clearly you're picking up cocaine, all kinds of things, and they say, oh, doc, I don't know what happened. I was at a party and someone breathed smoke into my face, and, I have no idea. It's a very different scenario to the person who says, I have to acknowledge I am out of control, I can't stop. Very, very different stages of change. I think that some ways to think about the immediacy and where the intervention should lie might involve. ASM is the American Society of Addiction Medicine. They've got some criteria. These are complicated criteria. I'm not going through them, but just some of the dimensions that they think about in terms of thinking about this patient and the immediate risk and whether this patient needs to be referred to some outpatient counseling, whether you can just sit for 5 minutes and talk to this patient and bring them back, in a week or 2 weeks or whatever it is, and see them again, whether you need to refer them to an outpatient treatment facility or inpatient, whether you need to refer them to to the emergency room, whether you need to call security and escort them somewhere because you think they're at such high risk. So dimension 1 is acute intoxication, withdrawal potential. If someone is obviously intoxicated in your office and they've double parked their car outside pack and they can hardly walk, you probably are going to think twice about letting them leave. If they're nodding off in your office and their lips have a slightly blue tinge, it's a different scenario. You also want to think about the withdrawal potential. Someone who says, Doc, I have to acknowledge I'm using 10 milligrams of Xanax a day, and I've just run out and I can't get any more and I've got no money. There's a severe withdrawal potential risk. So I think that's it. Someone who says, well, on weekends maybe I'm taking a few more of those Apana or whatever it is you're prescribing me, and I have to say that but in the week I don't. It's also a different scenario. The second is the biomedical conditions and complications. How severely ill is this person? Someone who's elderly, someone who's very severely disabled, someone who has severe medical conditions where there's a much higher risk in terms of withdrawal. You may think differently to someone who's still fairly healthy, who may have an old back injury with severe pain, but otherwise is healthy. The third is you want to look at psychiatric and cognitive complications. Is this person at high suicide risk? Is this person psychotic? Is there some level of cognitive impairment or dementia? The fourth is readiness to change. As I said, is the person in complete denial, or is the person saying, I need help? The fifth is, what's the relapse potential? Someone who has tried 10 times to quit and keeps just, popping up back in active addiction. And the sixth is the recovery environment. Do you have a supportive partner or parent or family member sitting saying, I'm going to look after this person, I'll take control of the medications? Or is this someone who's like semi-homeless, living in a semi-shelter? Different scenarios. I don't know if you're aware in the Bernstein building that there's basically a detox rehab treatment group called Stuyvesant Square. And I don't know if you're aware that 4 floors of the Bernstein building are dedicated to substance abuse. There are 2 floors, that's 5 Bernstein and 9 Bernstein, that are pure detox floors. Short-term detox. Patients stay there from a few days up to a week. There is 1 floor, that's the 6th floor, dedicated to outpatient rehab treatment, and 1 floor, the 3rd floor, dedicated to inpatient rehab treatment. And you can refer the patients there. And that will be assessed, and there's a toll-free number that you can call or the patient can call. So just be aware of it. If the patient has Medicaid or other relevant insurance, they will take those patients. And they're a very good facility. If your patient will go there, you can refer, they will do an assessment and see what they think this patient needs. Patient can stay in the rehab up to a month. So I think it's a very useful facility, and I would certainly think about using it. There are certainly other places you can think about as well. The Realization Center. There are other places, and it's useful to just have some numbers available to think about. When you're sitting in that scenario, saying, okay, let me give you 2 numbers. Your homework to your patient is to go and please call up and find out, next time I see you, I want an action plan. If this is a less urgent problem, and I think probably a fair amount of the addicted, when you start picking up, it's not someone who needs instantly to be dragged off to an emergency room. So that's something to think about, and they will assess what this patient needs and admit the patient to one of the detox floors, and then we'll try and encourage the patient, if it's a more severe problem, to go further into one of their rehab. Now, really, when we're talking about detox, the chemical side of detox, we're talking about two classes of chemicals. We're talking about the opioids, which you know more about than I do, and we're talking about the sedative hypnotics, specifically the benzodiazepines. And I'll talk a little bit about both, and you've got the slides here, so we're not going to go through everything. But to understand from an addiction point of view, opioids, this somewhat crude diagram looking at opioid binding sites, and as we know, the brain has, and specifically mu opioid binding sites. These different areas, the thalamus, where there's some gating of pain, the locus coeruleus over here, where noradrenaline is innervated, certainly the spinal cord, in some of the limbic areas, in some of the higher cortical areas, and in all these areas, when you are chronically using opioids, you get a suppression of these receptors, and so you get ultimately, as you develop tolerance, you get an upregulation of receptors. The opioid works less well. There's another area, though, which is represented by this red line over here, which is very important to understand all this. Do you know what this is? Any guesses what this red line is here? It's a representation of what I'm terming the brain reward system. This is the area that we know is very important in pleasure and euphoria. And if you look over here, this is an area called the ventral tegmental area, which is close to the substantia nigra. And this is an area in the anterior striatum called the nucleus accumbens. And dopamine is the major neurotransmitter in the system. And we know that the opioids have a somewhat different effect in this area. They really serve to kick out dopamine, to stimulate dopamine. So if we think of the effects of getting a nice big dose of an opioid, of morphine, there's an anxiolytic effect. You feel relaxed. It's suppressing the secretion of noradrenaline in the locus coeruleus. There's also a calming effect. There's both a physical and a mental pain relieving effect. But there's also in this area a stimulation of a euphorogenic effect. So over here, with chronic use, we get a downregulation opposing the stimulatory effect of opioids. And that helps us to understand what happens in opioid withdrawal. Stephen Stahl has represented it here, where all these areas are now upregulated. So you suddenly stop the opioid, and you've got an overfunctioning of all these areas, which starts explaining some of the symptoms of opioid withdrawal: the anxiety, the dilated pupils, the tremor, the sweating, the tachycardia. In here you can see hyperstimulation of the locus coeruleus. But the mesolimbic pathway of the brain reward system is now completely downregulated. It's got so used to having having its backside kicked by the opioid that suddenly you're taking the opioid away, you have an understimulated brain reward system. So you also have the intense dysphoria, the displeasure of not having that opioid. So you not only have the physiologic symptoms, but you also have the emotional symptoms. And there's a very good paper written recently by George Koob, where he's coined a term for the emotional equivalent of hyperalgesia, which he's coined hyperkatifia. The emotional sensitivity that comes. Hyperalgesia, we know, is the upregulation of the pain system, the sensitization, but there's probably an equivalent upregulation of our emotional experience of pain too. And anyone who's seen anyone in heroin or opioid withdrawal will see exactly. You say, get a life. Is it that difficult? They're gibbering wrecks. They look like they've got a severe case of flu. Their noses are running. They have zero pain tolerance. Certainly you could make a case for hyperalgesia in the short term of anyone who's in withdrawal. And it's probably accounted for by the physiologic nature of it. In terms of our approach, it's rather simple, which is that we try and substitute short-acting drugs that are very powerful, that give very powerful rushes in the brain, with a long-acting drug like methadone, which doesn't doesn't throw you into this high, but stabilizes the receptor system so you are comfortable, and then you can slowly withdraw it in a way that doesn't that allows the physiologic withdrawal to be mediated. So methadone, similar to propoxyphene. As we know, propoxyphene has just been taken off the market because of cardiac arrhythmias. The interesting thing is we all know methadone can also be associated with QT prolongation. And propoxyphene structurally is not that far from methadone. So, there's a big debate about, to what degree should we be doing EKGs on methadone patients. I don't know how much you do it in pain clinic, but it's certainly a debate. And methadone is a useful drug because it has a good oral bioavailability, it has a long half-life, it's a powerful pure opioid agonist, we can use it to stabilize the system. In methadone maintenance, they talk about an agonist blockade. I'm not going to go into this slide. If you use a magnifying glass, you can see it on your paper. But essentially, it's just looking at how to detox from methadone. I don't know if any of you are ever in that situation where you have to try and detox people. Just a few pointers in this. From a detox point of view, pain is different, but from a detox point of view, the maximum amount of methadone we can prescribe in 24 hours is 40 milligrams for detox. You cannot prescribe more. A methadone program can prescribe more, but I cannot prescribe more than 40 milligrams on my inpatient unit. It's a maximum for detox. You know why 40 milligrams is the cutoff? Because in a non-tolerant individual, above that can be a potentially lethal dose. So if someone makes a mistake, and this is not opioid withdrawal, you can kill your patient more than that. Up to 40 milligrams, you'll make your patient pretty sedate, but you won't kill. So that's the reason for the cutoff. Legally, we're not allowed to use more than 40 milligrams. Pain patients are different. You can do what you like.
The only thing you have to write on the prescription for pain.
Right. But certainly look, I can't, there are very few people who can prescribe methadone from an addiction perspective. Only methadone, official licensed methadone clinics can do it. So there are a handful of private clinicians who prescribe methadone. Ed Salsis, for example, can prescribe methadone. He was sort of grandfathered in. I don't know if you know him. So just keep that in mind in your use of methadone. Buprenorphine increasingly becoming popular. There's the structure. The central black structure is morphine. You substitute these groups and you get all kinds of things. You substitute this, you get naltrexone, a pure opioid blocker. You get buprenorphine, a partial agonist. You get all kinds of interesting things by just playing around with these different molecules. And buprenorphine is becoming more and more popular over the last decade or decade and a half. I don't know how much buprenorphine you're using in pain clinic. It's also become... Are you using much of it?
Much? No, I mean, like 3 or 4 patients. I don't have clinics, I have my own clinic.
Now there's a patch for it, which is going to be a lot easier to use. It's a weekly patch.
Yeah.
For pain.
For pain.
Exactly.
Yeah.
In terms of, we do use it for pain as well. I know we can prescribe, but you need a special license anyway.
Yeah, well, it's not very hard to get. All you do is it's called the Data 2000 waiver, Drug Act treatment of drugs.
Actually, that's not exactly true because I had DEA coming to my office.
Yeah.
And they wanted to see the record of all the patients. And they said, if you treat for pain, you don't need any special.
Yeah, for pain you don't.
The regular DEA.
Those of us in addiction circles are jealous of the pain prescribers because you can prescribe, but it's illegal.
But if you do it, if you write it's for...
Yeah, it's illegal for you guys to prescribe methadone or buprenorphine for addiction. It's illegal for me to prescribe those drugs for pain. It's bizarre, but that's how it works. And, there's a...
You can give it for pain. If you're a doctor, you can give any medication.
Well, Suboxone is specifically used for addiction. Also, the concentration we're using, 2 or 8 milligrams, is a fairly high concentration. I would feel very, very wary.
Suboxone for pain.
Yeah, no, you can use it.
That's what the DEA people told me.
But you can use it, but I am not allowed to prescribe it for pain.
I think every doctor is allowed to prescribe anything except for methadone for addiction.
Yeah, I don't think I am. I can check on that. I think that's the Data 2000 waiver is specifically for addiction purposes, for opioid dependence.
If you use the X number, the XDA number.
I have
If
an
you use
X
the
number,
regular
yeah.
DA number,
Yes.
pain, then you don't need it.
Yeah, but using the X number means that you're using it for
Right,
addiction
right.
disorders. And if I don't use my X number, they won't accept the script. So what I'm saying is the X number is essentially a contract to using it for addictive
This I
disorder.
don't know. I
Yeah.
never prescribed it, but this
Yeah.
DA people told me if you write it for pain, you don't need the X number.
A few pointers with buprenorphine, because it's a partial agonist, some people call it an agonist-antagonist, one has to be very careful in giving it to people who are still actively using. So you really need to use it because someone who is actively using a pure agonist, you suddenly give buprenorphine, which is a very sticky drug in those opioid receptors. It's going to displace whatever other opioids they're using and trigger instant precipitate withdrawal. So you're going to have a very unhappy patient. So moving patients from a pure agonist to a partial agonist involves the fact that they need to go through some level of withdrawal.
That conversion, 0.4 to 10, less 10 of morphine orally?
Yeah, I think so, yeah. I mean, these are rough conversions because the problem with a drug like buprenorphine is it has a ceiling effect. So it's not a linear effect. But certainly at low doses, buprenorphine is a very powerful analgesic in someone who's not tolerant. So it's a useful analgesic. Like you were saying with both these drugs, if we were using it for pain or we had patients on them for pain, I would start giving them, dividing the doses up 3 times a day, 2 times a day, 3 times a day, even though the half-lives of these drugs and the dissociation half-lives are longer.
To avoid putting them into withdrawal?
No, I'm saying if you have patients who also have pain problems on top of on top of the addictive disorders.
The same as methadone, you say.
Yes, you would.
Addiction you do once a day,
Y-
pain you do
yeah.
3 or 4 times.
Yes. The only thing to be careful with methadone is, where I've seen pain doctors get into trouble, is when you're putting people onto methadone and you're building it up, and because of the potential long half-life, you're building it up, there's not much of effect, you're building it up, and all of a sudden, someone is overdosed. And that's where deaths have occurred, particularly if they're also using other respiratory depressant drugs like benzos or alcohol. So that's where you have to be careful.
Especially with buprenorphine, the benzos are almost a contraindication.
Well, no more or less than with methadone, but that's where we see deaths, is when people are combining other opioid. Buprenorphine is actually a pretty safe drug to use. You've got to take a fair amount to overdose, and because you get the ceiling effect, the antagonist effect starts to increase as you move up. But if you are combining with other things, then you are potentially moving into trouble. This is just some suggestion if you ever need to use it for detox purposes. And don't forget also in your patients where you're trying to get them off opioids, the adjunctive medications, particularly the alpha-2 adrenergic agonist agents like clonidine, that may be useful, and other symptomatic medications.
I give them something.
What do you give them?
Sometimes some clonidine, but I had only 2 or 3 patients that wanted to.
Yeah, just keep in mind when you use clonidine that you've got to use enough. We tend to probably underuse it, up to 0.075 to 0.3 milligrams 4 hourly, which is a fair amount of clonidine to use if you're going to use it. And some dizziness and hypertension is possible, but it does at least modulate that locus coeruleus overdrive. Now, just another point to keep in mind. This is a study from JAMA some years ago where they looked at methadone patients treated for opioid dependence. They kept them on methadone for 6 months randomly and then detoxed them versus another group that they kept for a year. And look what happened. Here is mean days used. Here's proportion of patients using heroin. And look at 6 months. The black line here is those who were detoxed. Look what happened when they were detoxed after 6 months. And these were all patients that were also getting very active other group and supportive treatments for addiction. Look at how their use went up. Similarly, this is a Danish study, but it's fairly dramatic, where they took 40 subjects. This was a double-blind, placebo-controlled study where they took 40 subjects, and half of them they kept on a decent dose of buprenorphine, and half of them they put onto a placebo without them knowing. And look what happened. Those on the buprenorphine maintenance for this is 350 days. 75% 1 year retention and 75% negative urines. That's pretty good, by the way. Versus those who were detoxed, look at how they fell off. And what was very concerning was that the mortality, these were all heroin addicts, 4 out of 20 of those who were detoxed, overdosed and died, where 0 out of the 20 who were kept on buprenorphine maintenance. So just something to keep in your mind when you are dealing with patients that you're identifying as chronic opioid abusers, that this is a very, very sticky drug, and the relapse rates are extremely high. You're dealing with essentially a chronic disease, and without a very, very multifaceted approach, a lot of these patients are going to continue in that cycle of addiction, and some of them are eventually going to die from it. I think I'm going to stop here. You've got the notes for benzos. Nice to meet you.